An overview of where TAVI has come in the last probably 9 to 10 years. So there are clearly challenges with TAVI today. Paravalve leak, permanent pacemakers, patient selection, I think is a big issue. Vascular complications, stroke, predictable implant, coronary occlusion, annular rupture, ventricular perforation, and more recent, I think, valve durability has been questioned. But there are also, I think, administrative challenges with TAVI today. The overall cost, I think, is still prohibitive for a lot of centers, certainly in third world countries. Patient flow, managing increasing volume is becoming a challenge. And finally, patient choice. I think increasing those centers that are doing TAVI today will grapple with this challenge quite frequently. Patients coming to you with a volume about TAVI and asking for that specific treatment. However, it is a standard of care, I think, for high-risk patients and inoperable patients with symptomatic severe stenosis. The overall numbers are increasing in each unit that are doing TAVI today. Increasingly, the so-called moderate risk patients are being offered TAVI. And I think this increase will increase more driven by data and patient choice. For the purpose of this talk, I'm just going to concentrate on 4 commonly used valves today. You see the balloon expandable Edwards SAPIEN device, the self-expanding supraannular Medtronic device, the St. Jude's annular portico device, and the mechanically expanded Lotus device. You can see from the pictures alone, they all look very different. The functions are very different. The deployment characteristics are very different. Edwards SAPIEN, first of all, have gone through significant changes from the SAPIEN valve XT to the SAPIEN 3. And certainly when you look at how the valve is loaded, also you can see just on pictures again, from top to down, the crimping size has changed, the need for access has changed significantly. So has this affected outcome when you look at global trial? I'm not going to spend too much time on the data itself, but the PARTNER 2 trial has looked at surgery versus TAVI in moderate risk patients, and it included actually all 3 valves for the purpose of the duration of the trial. So it gave us a good insight on what each valve specifically linked to outcome. I think it's quite interesting. In the US, it was called a moderate risk trial, but the average age of population for this trial was 82. And about a fifth of patients actually had previous bypass surgery. So again, you can already see that the concept of moderate risk, I think, has changed from the day this trial was presented to what we do today. This trial showed that the outcome of TAVI, at least the transfemoral outcome of TAVI with surgery, was non-inferior. But there were challenges with TAVI, clearly. There was a fairly high event of moderate risk, moderate paravalve leak, with almost 8% showing evidence of paravalve leak at up to 2 years follow-up. And we know that paravalve leak, at least moderate to severe, correlates quite poorly with outcome both at short and long term. There were other significant challenges with the balloon expandable. The need for second valve was at least 2.6%. Valve embolization was noted. Annular rupture, catastrophic event was seen in 3 patients. Coronary obstruction and exercise infections were again seen as challenges. So the SAPIEN 3 valve has been developed. It is unique in that it has an external skirt and that allows the device to take on paravalve leak. And it also, the delivery system also is able to bend in 2 points, one at the annular point and one at the arch, allowing for us to position and deploy the valve a little better. And this has resulted in a significant drop in paravalve leak from 8% up to 3.5% at 30-day follow-up. And when we looked at more detailed analysis of outcome towards, or paravalve leak outcome towards sizing, it was seen that, and similar to other devices, if you oversize the valve by 0 to 5%, 5 to 10%, and the more oversizing you put into the sizing of the valve, the better was the outcome. However, you need to balance that towards potential risk of annular rupture if you oversize it too much. And vascular complication again significantly dropped from the double digit to single digit, again due to the low profile of the device. And when you look at overall 30-day outcome compared to the early trials, significantly lower now with the SAPIEN 3. But perhaps it's because we are getting better at selecting the patients. Certainly if you look at their STS score from the early trials to what we did now, an STS score of 11.6 right down to 5.2. So perhaps patient selection has played a significant role as well on how TAVI has improved over time. but there is perhaps something to give up. So when you put a skirt around a valve, there's more interaction at the annular plane, and what people have seen and what we have seen is there is marginal increase in the need for pacemaker even in the Sapien technology. But by better technique, we've gone back to about single-digit pacemaker requirements even for the Sapien. So the next generation Sapien will be on a Sapien 3, but will be preloaded and a much lower profile with the Exceller sheet coming down to about 14 French equivalent, which is a huge step compared to say 18, 19 or 22 French device. We then come to Medtronic CoValve. It has gone through a significant change again from the early generation to what we have now, and a much larger valve size availability. The CoValve US IDE trial was the first trial to show in the high risk and inoperable group TAVI to be superior, even up to 3-year follow-up. Once again, there was something you give up. There was a much higher need for pacemaker, almost 28% requirement for pacemaker. Re-intervention again, 2.5%. And paravalve leak significantly higher, almost up to 7 to 8% or moderate severe when compared to surgery. So the Medtronic Evolut R then was designed to have a more conformable valve. Because of the calcification, self-expanding technology is very dependent on what the anatomy is given. So the valve conforms the anatomy, and hopefully by doing that, it doesn't create pockets for paravalvular leak. And the delivery system is now probably the most lowest profile delivery system for all TAVI devices, in that you can advise the valve sheathless, removing the need for a sheath, and that significantly drops the requirement for excess size. And certainly in our unit, since the introduction of Evolut R, our need for alternative access, surgical access, significantly dropped from double digit to about single digit now. When we looked at the outcome, we were fortunate to be part of all these trials. At 30 days, we had no major outcomes. Even at 1 year, 1 year mortality was down to 6.7%, which is probably one of the lowest 30-day mortality for a TAVI trial in this cohort of patients. And certainly when you look at, for the CoValve series, at least comparing to the earlier generation device to where we are now, it has significantly dropped in terms of 30-day outcome. So perhaps I think new devices with this iteration, better patient selection, and the use of CT, I think is impacting on how this generation of devices help. And the key thing we've noticed, there was a significant drop in the need for pacemakers from 20% down to 11.7%. And again, I think by having the Evolut R with this resheathable feature allows you to deploy the valve slightly higher, and if it's not good enough, you can go slightly higher again, and then you're not affecting the left bundle area and causing trauma to the left bundle. And again, we were able to do a more detailed analysis of the patients who did get a pacemaker versus the one who didn't, and deployment positioning was a key factor. So if you drop the deployment depth less than 6 millimeters, that impacted on pacemaker need. If you go slightly higher, it reduces the need for pacemaker. Paravalve leak again was reassuringly significantly better from the early trial design to about 3.4 to 4% or moderate. There was no severe. I think we can still go some way to get it better to surgical-like results, but certainly in this high-risk group, it is acceptable, I guess. So the next iteration was the size 34 valve. Now, for 34 sounds massive for a surgical kind of valve, but these valves expand to fit the space, but it has increased our ability to treat much larger annulus from 26 to 30 millimeter diameter. The next generation Evolut R Pro should be available in about 2-3 months' time. Certainly it's available. The trial's been completed in the US. This valve has an external skirt similar to the Sapien 3. And again, it's trying to address the paravalve leak component of one of the challenges with TAVI today. We come to Portico then. This is now what was owned by St. Jude's. St. Jude's now been bought over by Abbott, so it's the Abbott Portico valve. And it's an annular functioning valve, bovine leaflets, and has a much larger configuration of cells that enables easy access to coronary artery, which will be a challenge and maybe a potential thing we need to look at once we start treating, or if you start treating low moderate risk patients. And when we look at results, 30-day mortality and 1-year mortality, similar to the first generation to second generation interchange. So this is Abbott's or St. Jude's first iteration. And when we look at paravalve leak, I think slightly higher than what you'll expect today, but for their first generation device, between 5 to 6% of moderate PVL with no severe. The next generation of Portico will be far more compliant, more deliverable, And again, there is a sheetless technology coming, and and addressing the power leak, it will have an external skirt, a dedicated external skirt to match the Sapien and the Evolular Pro. So finally, then we come to the Boston Scientific Lotus valve. This is a unique device. It is very different from the self-expanding and certainly different from the balloon expandable. This device is made from a mesh of nitinol, and before clipping, it's a elongated device of 7 mm in diameter, and it's mechanically compressed to form the valve. And it is the only valve today that you can fully deploy it without releasing. And when you release it, it stays where it is. And if you do not like where it is, you can fully reposition it and release it again. So it has that very unique property. It also has a very unique skirt outside, which bunches up to form it's probably the best in class in terms of skirts for power valve leak. And I'll show you some results on power valve leak and why I say it. So in terms of 30-day outcome, similar to what I've shown before, at 4.2% 30-day mortality, stroke 1.7, non-discriminating stroke 4.2. But you do lose in terms of need for second valve, because it is truly a valve when fully released or fully in position, you can fully decapture it. There was no need for a second valve at all compared to the Edwards Sapien or even the Portico or the Evolular. But you do lose something in exchange. Sorry, before I go to that, in terms of power valve leak, it is the best in class. We do not see any moderate, we do not see any severe. Even if you look at the mild, it's single digits or less. So it has clear advantages in terms of power valve leak, but it has a significantly higher need for pacemaker. For 2016-2017, the pacemaker rate is almost 25 to 28%. So I think there is something about having an external skirt and how it interacts with the outflow area. Again, Boston has gone through a couple of iterations trying to deploy the valve a little higher, and at present, the company has withdrawn all its technology from the market due to locking challenges. We hope that we will have this technology back in the market by the end of this year, early part of next year. This is what the next iteration should look like, is the Lotus Edge, and it's supposed to be leaner, smaller, addressing extra challenges, but much larger valve sizes as well, and smaller valve sizes. So to summarize then, I think technological advances has positively impacted on TAVI outcomes. I think the overall improvement outcome has been due to, I think we've been better at patient selection, we have been better at deploying the valves and getting access. But with each change in technology, I think we do need to change our technique in deploying these cases and deploying the valves. But finally, I think no matter what you do, whatever technology you get, you really have to still pay attention on how you select your patients, how you do your procedure, when you do it, with who you do it, and more importantly, following these patients after the procedure as well. I think those are key areas. Thank you.